Afternoon and welcome to Get With the Guidelines. My name is Valerie Andel and I'm here to talk to you today about temperature management. I have been a nurse at a level 1 trauma center for approaching 25 years. It is a teaching institution, and so I've had the pleasure of being involved in many educational aspects to include policy and protocol development and implementation. Additionally, I have my license as an administrator for long-term care, and I actively support and advocate for post-acute health care. I have disclosed that I do have an affiliation with Zoll Medical. Continuing education for nurses. This activity has been approved for 1 contact hour for nurses. A link to obtain your certificate will be available at the end of the presentation. The accreditation statement. Sachs Healthcare Communications is accredited as a provider for continuing education. Provider approved by California Board of Nursing. Support for this activity has been provided by Zoll Medical. All right. So first of all, our learning objectives. At the end of the presentation, you will be able to identify at least 3 updated American Heart Association guidelines, explain the benefits of fever avoidance after return of spontaneous circulation, be able to identify 2 or more potential complications associated with targeted temperature management, and propose appropriate nursing interventions to effectively manage these complications. Cardiac arrest in the United States. Annually, in the United States, approximately 475,000 Americans die from cardiac arrest. More than 350,000 of those cardiac arrests occur outside of the hospital, so roughly 74%. Steps must be taken to improve outcomes, especially for the out-of-hospital cardiac arrests. Timeline: 2 decades of temperature management. In 2002, Bernard published studies that indicated hypothermia to be beneficial in the post-cardiac arrest patient. The degrees that were tested were 32 to 34 degrees. By 2010, the American Heart Association upgraded this to a Class 1 recommendation for cooling post-cardiac arrest patients. They indicated degrees between 32 and 34 degrees. Like I said, when I was a nurse on the floor, I absolutely remember when this study came out, we began cooling patients. We were cooling all post-cardiac arrest patients that met criteria. We were using any means possible to get them cold. The patients were cold, the nurses were cold, the floor was wet. We were doing whatever we could to cool these patients. By 2013, the TTM trial published their studies indicating that there was no difference in the outcomes between 33 versus 36. This created a great deal of confusion and misinterpretation about how to treat post-arrest patients. The one thing that the TTM trial did not say is it did not say do nothing, but this is how it was interpreted. Again, I completely remember being in the ER, this study came out, and we virtually shelved cooling post-cardiac arrest patients. Even so, by 2015, the AHA continued with recommendations and expanded the range 32 to 36 degrees. They continued to call this a Class 1 recommendation to cool post-cardiac arrest patients. Since the release of the TTM in 2013, ongoing debate and data collecting occurred. It was becoming abundantly clear that since 2013, noncompliance with temperature management in post-cardiac arrest patient was resulting in worsening patient outcomes. Thus, in 2019, one specific study was the Hyperion study, which showed TTM to 33 was beneficial even in non-shockable rhythms. Remember, post-cardiac arrest care and cooling was originally for only shockable rhythms. But in the 2019 trial with Hyperion, it showed to be beneficial to 33 to non-shockable rhythms as well. By 2020, the AHA guidelines again expanded their Class 1 recommendations to include cooling for post-cardiac arrest patients from 32 to 36 degrees. They also included cooling for post-cardiac arrest pregnant patients. By 2021, the TTM2 trial had been published indicating no difference in the outcomes between the 33-degree group versus the fever control group. However, in 2023, the American Heart Association expanded the class 1 recommendations to include target control range from 32 to 37.5. As you may well already know, there have been many studies on post-cardiac arrest care and temperature management. These studies basically can be grouped into some common categories that we have listed here. First, we have outcomes. Obviously, discusses specific outcomes of post-cardiac arrest care and cooling. We have control and precision, meaning maintaining precise control of temperatures desired. We have time to target temperature, which is very important. And just most recently in the Annals of Emergency Medicine, published in November 2024, a study was published discussing the importance of early pre-induction of cooling, that it is associated with improved outcomes following out-of-hospital cardiac arrest. This was by Beacom. This means that time to target temperature matters. There's also studies that support nursing workload. It discusses burdens of workload for nurses with respect to how they cool post-cardiac arrest patients, either using surface versus intravascular devices. And again, more studies on the safety and efficacy of post-cardiac arrest care and cooling. Additionally, in 2024, the European Journal of Anesthesiology published this article on neurological outcomes with the use of mild therapeutic hypothermia. Study's aim was to compare neurological outcomes between patients treated with and without mild therapeutic hypothermia after cardiovascular arrest based on data from a large multi-center resuscitation registry. In this study, it looked at over 34,000 patients suffering from out-of-hospital and in-hospital cardiac arrest. Basically, the results of this study suggest that mild therapeutic hypothermia has a neuroprotective benefit and support the continued use of MTH in patients with coma following successful CPR. The differences between the data in this study and the TTM1 and the TTM2 trials are speculative, but may be due to the significant differences in bystander CPR. TTM1 trials and TTM2 trials had very high percentage of bystander CPR, sometimes in the 80%. Bystander CPR rates from TTM trials do not correspond to the reality of many resuscitation registries. Most commonly, the bystander CPR rate is 20 to 30%. Authors postulate that the neuroprotective effect of the MTH is significantly more pronounced in a population with lower bystander resuscitation rates and longer ischemic times. This also fits well with the results of another major study of MTH in recent decades with bystander CPR rates of less than 50%, such as the HACA trial and the retrospective cohort study by Testori et al. The basic idea here is that temperature management may be more beneficial on those people that did not have CPR, had longer downtimes. The TTM1 trials and TTM2 trials, with their results, were based on patients that had high rates of bystander CPR. All of this to say that this is and will continue to be a very well-researched modality. Next, we're going to compare the TTM1 trial and the TTM2 trial in the next several slides. This is just to give you an idea of what they were looking at and a breakdown of the patient population that was studied. In TTM1 and TTM2, the randomized groups were randomized to either 33 versus 36 for TTM1, and in TTM2, it was 33 versus fever control, so managing a temperature and keeping it between 36.5 and 37.5 Celsius. The size of the study for TTM was 950, and the TTM2 trial was significantly larger with 1,900 patients. Treatment inclusion, all patients were actively cooled in TTM1, and in the TTM2 trial, all patients in the 33-degree arm were actively cooled. The patients in the fever control arm had almost 50% of the patients with active device management, meaning they needed to be actively controlled so that they did not fever. Cooling methods in the TTM1 trial, surface and IVTM were used, so intravascular temperature management. And in TTM2 trials, devices varied. It was surface and IVTM with adjunctive cooling methods, nasal, esophageal, ice packs, cold saline infusions were also allowed. So there was a variable way to cool the patients in the TTM2 trial. Medication management in the TTM1 trial, it was performed per site protocols, as was the TTM2 trial. Again, moving on to comparing the two studies a little more. Patient demographics in relation to hypoxic injury. So here's the outstanding differences between the study that the EGA reported and the TTM1 and TTM2 trials. So in the TTM1 trial, 73% of the patients had CPR, bystander CPR. No flow time was recorded as 1 minute. In the TTM2 trial, bystander CPR rates for the 33-degree Celsius arm had 82% CPR bystanders. That's an astronomically high number of bystander CPR. For the fever control group, 78%. Again, very high rates of bystander CPR in these two trials. Cooling initiation and time to target temperature both had long delays in time to target temperature in the 8-hour range. As you can see by the long time to target, that could affect the outcomes. Rewarming rate. In the TTM1 trial, it was acceptable to rewarm at 0.67 degrees Celsius per hour. And in the TTM2 trial, they did 0.33 Celsius per hour. Normothermia maintenance in cooled patients. So once they had been cooled for the determined amount of time, how long did they maintain normothermia? And that was not reported or not done in either trial. Looking at survival at 6 months, you can see in the TTM1 trial, if they were in the 33-degree range, they had a 52% survival rate at 6 months. And in the 36-degree arm, 53%. For TTM2, it was roughly the same, very close. The 33% had 50% survival at 6 months, and in the fever control arm was 52%. So really negligible survival rates there. Good functional outcomes at 6 months, again, very close here. In the TTM1 trial, you have 33% and 36%, with 48% of the patient population with good functional outcomes at 6 months. And 45 for the TTM2 trial. Interpretation of the TTM2 study. So TTM2, just as TTM1, does not say do nothing. Let's be clear. It does not say that you should not cool. It does not say that you should not prevent fever. It does not say choose between cooling and fever management. It does not say results can be applied to all patient populations in all geographies. Look at the differences of the data points between the Pennsylvania and Germany studies compared to the TTM2 trials. All studies were looking at the same neurological outcomes. The one I want to really highlight is the bystander CPR. On average, 82% of the TTM2 trial received bystander CPR. That is an astronomically high percentage for bystander CPR. Most commonly, as you can see in the Pennsylvania and German study, it's in that 30% range. These data points of TTM2 are precisely what the European Journal of Anesthesiology are speaking to when they reported out their data. Okay, so now that we have reviewed some of the studies, let's talk about fever in the ICU. What does fever in the ICU do? Well, fever in the ICU increases length of stay. Fever is associated with increased length of stay and higher mortality. It adds 2 additional ICU stays and 4.3 additional hospital stays, thus increased financial burdens to hospitals and patients. If you have a cerebral infarction, fever Elevated temperature is associated with poor outcomes after stroke. If you have a subarachnoid hemorrhage, the fever burden independently is associated with mortality and poor functional outcome. And if you have an intercerebral hemorrhage, the duration of the fever, if it's greater than 37.5 in the first 72 hours, is independently associated with poor neurological outcomes. So fever is not good for injured brains. So what should we do? Again, in 2020, the American Heart Association updated their guidelines. Temperature control indication for post-cardiac arrest patients, unconscious patients who achieved ROSC remain a class 1 recommendation. We will discuss what a class 1 recommendation means shortly. Their updates in 2020 also included target temperature range upper limit has been updated to 37.5 with a full range of temperature control from 32 to 37.5 degrees Celsius. The recommendation for slow and controlled rewarming after maintenance of target temperature defined as 0.25 degrees Celsius per hour up to, but not greater than 0.5 degrees Celsius per hour. So once the patient has had their full length of cooling and it is time to bring them slowly controlled back up to normothermia, it is a slow and controlled rewarming process. And again, the AHA focused update in 2023 released that the evidence is still strong to continue with temperature control protocols in this patient population. So again, we must manage the temperature in our post-cardiac arrest patients. Avoid fever, control that temp. Temperature control indication for post-cardiac arrest unconscious patients who achieve ROSC still remains a class 1 recommendation. I want to really highlight that this is still the recommended approach to treating post-cardiac arrest patients who are unconscious and not following commands after ROSC. What does a class 1 recommendation mean? Well, a class equals strength of recommendation. As you can see, it is a graduated ranking and has some subcategories. I'm not going to go into all the details of the subcategory, but as you can see, class 1 is strong, and that is where temperature management for post-cardiac arrest patients lies, is in this green box. It is a strong recommendation that you cool post-cardiac arrest patients or manage their temperature. Okay, cerebral ischemia. How does it work? So cardiac arrest happens and blood flow to the brain stops for an undetermined amount of time. What happens to that brain tissue when it becomes ischemic? This ischemic event triggers a chemical cascade. So you have electrical depolarization, you have cytoskeleton breakdown, you have the blood-brain barrier breakdown, you have release of neurotransmitters, you have oxygen radical production, activation of protein kinase enzymes, and temperature affects all of this. So our goal is to lower the body's temperature to suppress that inflammatory response. I want to give you an example. Let's go back to our chemistry class when we were in high school. What did we do when we wanted a reaction to speed up? We got out our Bunsen burners and we gave it heat so we could speed that reaction up. That is what happens when a patient has fever. This whole reaction speeds up and leads to inflammation in the brain. Reperfusion injury. What is it? Well, this is a little tricky and it seems counterintuitive because you think giving oxygen back to ischemic brain cells is a good thing, right? Well, if it is done too fast, brain cells have a negative reaction. The easiest way to define a reperfusion injury is when cell apoptosis occurs after the ischemic tissue is reperfused with oxygen-rich blood. This leads to additional injury in the area of the initial insult. Dr. Lance Becker once referred to this as when the cells are reperfused, they commit suicide at the moment of their salvation. Okay, why does temperature control matter? Well, favorable cellular responses to hypothermia are stabilized blood barrier, decreased release of exocytic neurotransmitter, decreased release of calcium, decreased formation of free radicals. So when you decrease all of those things and you stabilize that blood barrier because your patient's hypothermic, you're going to decrease swelling in the brain. What does that mean clinically? Well, decreased swelling, obviously. And if you have decreased swelling in the brain, you're going to have decreased intracranial pressure. You'll have decreased cerebral metabolic rates. And for each degree Celsius you decrease the temperature, there is a 6 to 7% decrease in cerebral metabolic rate. So let's do the math. If you have a patient that goes from 37 degrees to 33, that's a 4-degree temperature difference. And on the low end, that would mean a 24%, and on the high end, a 35% decrease in cerebral metabolic needs. You will also decrease the cerebral oxygen demand, therefore decrease O2 consumption and CO2 production. And what does that mean? And what does that lead to? It leads to improved neurological outcomes. Fever occurrence in the neurocritical care patient. Why does temperature matter in this population? We touched on this a little earlier, but here are some findings. Patients with intracranial hemorrhage will fever 91% of the time if their temperature is not controlled. For patients with subarachnoid hemorrhage, 73% of the time. For patients that have a TBI, they will fever 68% of the time. And for folks with ischemic stroke, they will have fever at least 61% of the time. Again, elevated temperature can lead to poor outcomes in this patient population. For each increase of temperature, 1 degree Celsius increase in temperature will more than double the risk of a poor outcome. Duration of the fever is also important. So if they have fever and the fever is within the first 72 hours, it is independently associated with poor outcomes in intracranial hemorrhage. Fever increases hospital length of stay and increases mortality. Again, like we spoke of earlier, 2 additional ICU days and 4.3 additional hospital days for folks that develop fever and do not have this control. This leads to increased costs and again, poor outcomes. Okay, why temperature control matters. Secondary brain injury refers to the changes that evolve over time. This can be hours to days after the primary brain injury. It is the major cause of death and disability of our patients who survive the primary injury itself. I think that this is a good picture that demonstrates the 2 previous slides that we talked about. So on the left-hand side, you can see fever. It will accelerate that injury. Remember, what did we do to increase our reaction in chemistry class? We heated it up. So if you let the patient fever and their temperature goes up, you're going to increase that potential for that secondary injury and brain swelling. When we want to preserve that brain tissue, we cool them. You can see that the arrows are pointing to primary and secondary injury. The dark black spot in the middle is the primary injury. So that's the initial injury during the initial ischemic event. And then the red circle represents the risk for the secondary injury post-ROSC. Shivering, the cold truth about shivering. Why do we shiver? We shiver to get warm and generate heat. And this is the body's mechanism and its thermal regulatory response to changes in temperature. So we shiver in response to changes in our body temperature. When we shiver, what happens? We increase our metabolism, we increase our oxygen consumption, we increase our energy expenditure, and the production of carbon dioxide. We increase our intracranial pressure and our blood pressure, we increase our heart rate, and we also decrease our seizure threshold. So if shivering is not managed, this may negate all the neuroprotective benefits of TTM and definitely prolong the time to target temperature. It is very important to do Q1 hour shivering assessments, if not more, if needed. It is imperative that you address any shivering as soon as possible using a step-by-step approach. Shivering. What you see on your screen here is a very basic bedside shiver assessment scale. This is a graduated approach. It is a continuum. And as you can see, if they are not shivering, they have a score of 0. If they have some mild shivering, they would have a score of 1. And you would see these shivering, with a mild score of 1, you would see shivering localized in the neck or the thorax. And it may be only seen as artifact on an ECG or felt by palpation. Very important to put your hands on the patient and see if you can feel some of those micro shiverings at this stage. As it progresses, you've got the moderate and more severe. Again, it is imperative that you use this bedside shiver assessment scale to guide your assessment of your patients and provide appropriate medications or follow your protocols to control shivering. On the screen now, you can see an example of an anti-shivering protocol. This is just a very basic anti-shivering protocol. Many institutions have developed their own protocols, and it is very important that you follow the protocols that your institution has established. For example, at my institution, our protocol gives an initial dose of a paralytic at the initiation of cooling to get ahead of the shivering. I equate shivering management to pain management. The point of this is to get on top of shivering and stay on top. Shivering and fevers, that is the enemy of post-cardiac arrest care. How to rewarm. Take it slow. Recommendation is for a slow and controlled rewarming after maintenance of target temperature. A slow rewarm is defined as a range, 0.25 degrees Celsius per hour, up to but not greater than 0.5 degrees Celsius per hour. Most commonly, I see a 0.3 degrees Celsius per hour for the rewarm. Potential side effects of rewarming too quickly are arrhythmias, electrolyte shifts, specifically potassium, hypotension, hypoglycemia, coagulopathy, and cerebral edema. Nursing considerations. First, be hypervigilant. Assess, assess, assess. Keep an eye on their vital signs, their labs, their shivering. Consider early counter-warming measures. This seems counterintuitive, but really a warm blanket on the skin can really help manage some shivering. Know your protocols. Know your bedside shiver assessment scale. Aggressively follow them. Follow those protocols for managing shivering, whether with medication or non-pharmacological interventions. Close monitoring of your vital signs, shivering, and labs. You want to do neurostatus checks. Are they starting to follow commands? Speak up if something has changed. And remember, your patient is cold, so they're going to be bradycardic. That's okay. This sometimes is a little disturbing, especially in a teaching institution if you have young residents. When you're cold, you'll be bradycardic. Treat shivering like it is pain. It is much easier to stay on top of it rather than playing catch up. Depending on the method of cooling, if you're doing surface versus IVTM, if you're using surface, make sure that you're frequently doing skin checks and monitoring for any skin breakdown under the pads. This can happen quickly. If you're using intravascular temperature management, follow your protocols for central line maintenance that are established by your institution. Okay, let's move on to a case study. This is a case study of a 19-year-old male. He had no past medical history, no cardiac history. He had a sudden and witnessed cardiac arrest while playing soccer. He had bystander CPR that was initiated immediately on scene. Medics arrived, and his initial rhythm was VFib. He had a total of 6 rounds of CPR and DFib prior to ROSC. He was transported to a local hospital about 10 minutes away. On hospital arrival, cooling measures were implemented via IVTM, and his target temperature was set at 33 degrees Celsius. Anti-shivering protocols were in place, but the patient was difficult to get to target temperature. Why? Well, initially, nurses noted that there was no shivering with this patient, but upon closer exam, the patient was noted to have micro shivering in his upper inner thighs and buttocks. What does that demonstrate? It demonstrates that even a little bit of shivering, that micro shivering, can make it difficult to get your patient to target temperature. So, additional paralytics were given to this patient per their protocol to control shivering. After Paralytics were given, the patient reached target temperature of 33 degrees Celsius in about 15 minutes. He was cooled for 24 hours. He then had a slow controlled rewarm at 0.3 degrees Celsius per hour to a temperature of 37. And upon reaching normothermia, he was maintained at 37 for approximately 48 hours. This 19-year-old kid walked out of the hospital completely neuro intact. He returned to playing soccer with his team. Highlights of this case include high quality CPR at the scene, following the chain of survival, initiating temperature control to prevent fevering, managing his shivering, slowly rewarming him, and managing normothermia to ensure the patient can self-regulate his temperature before removing this adjunct. Thank you so much for taking the time to listen today. To obtain your CE credits, please go to the link below. Complete the evaluation, the post-test, and upon successful completion, you will be able to print your certificate of completion. Have a great day.